One.
So, good morning, good afternoon, good evening, everyone. Thank you very much for joining the 24th EURADOS webinar. We are very delighted to have more than 400 participants. This webinar is organized by EURADOS Working Group 12. But let me start at the beginning to show some info on EURADOS. For those who are not maybe familiar with EURADOS, EURADOS is a non-profit association, and we are dealing with promoting research and development in the field of dosimetry of ionizing radiation, and the EURADOS is covering different aspects of dosimetry of ionizing radiation, from radiation protection to individual and environmental monitoring, radiobiology, to diagnostic therapeutic application of radiation in medicine. At present, we have more than 80 members, institutions, and more than 700 scientists, which are active and working in 8 working groups on different topics. If you are interested in more information, you can visit the EURADOS web page, where you can find all the information. So the work is divided in 8 EURADOS working groups, and also recently we have new pilot group. This webinar is organized by Working Group 12, Dosimetry in Medical Imaging, and my name is Željka Knežević, and I had the great pleasure and honor to chair this working group until 2023, and now the current chair of Working Group 12 is Paolo Ferrari from Italy. More information about all other working groups you can find also on EURADOS web page. Just a few information about Working Group 12. Working Group 12 is dealing with patient and staff dosimetry in the medical field, excluding radiotherapy. Radiotherapy topics are covered by Working Group 9, but we have also very close cooperation with Working Group 9 and also with Working Group 6 in Monte Carlo simulation. So this is joint work between different working groups. Working Group 12 is also very actively collaborating with IFOM, and in this presentation you will see the part of this nice collaboration. And the members of Working Group 12 are from medical physicist community, from research laboratory, reference laboratory, regulatory services, and so on. At present, Working Group 12 is divided in 2 subgroups. Subgroup 1 is dedicated to staff dosimetry, and here you can see a list of some of the active tasks which are ongoing now. And subgroup 2 is dedicated to patient dosimetry, and here also you can see the active tasks, and one of the tasks which was on the topic on reviewing the guidelines and recommendations on the use of out-of-field shielding in X-ray imaging was led by our lecturer today, Marta San Merce, and this was this task was recognized by GAPS initiative, and you will hear some of the results of this initiative between different societies in our lectures. If you are interested in the work and any of these tasks, feel free to contact us, to send us an email, and we will be happy if you can join and help us in our tasks. Also, the list of publications connecting to the both subgroups are available on the EURADOS web page. So we publish a lot of papers on different topics, and you can download all this information on EURADOS web page. Also, the webinars, as also this webinar, will be recorded, and it will be available on EURADOS YouTube channel a few days or within the week after this webinar. So not to take a lot of time from our very interesting lecturers and lecturers, I just want to give some few technical details. You can post your question and comments in Q&A sections, and after all lecturers finish their presentations, we will try to answer all of your questions. And also, we are happy to announce that this webinar is accredited and will be a CPD event for medical physicists, and it's accredited with 9 CPD points. And if you need a certificate, please send us an email on this address. So now I'm very happy, very delighted to introduce Dr. Marta Sanmerse. She's a medical physicist from University Hospital Geneva, and also she is a member of and representative of EURADOS, and actively involved in the activities of Working Group 12 dealing with dosimetry in medical imaging. She will show us information and results about regulation and current practice concerning shielding. Marta, the floor is yours.
Thank you, Zelka, for this very nice introduction. So, as Zelka already mentioned, I'm going to talk about regulations and current practice for patient contact shielding. So first of all, I have to say that I have no conflicts of interest to declare. I am member of the EURADOS Working Group 12, as Zelka mentioned, and I was member also of the GAPS committee. The objective for this presentation will be to learn about guidelines and recommendations and national and international legislations about the use of patient contact shielding, and to understand about the current practice of patient shielding in European hospitals. So before I start, let me just clarify one point. What is in-field shielding? So in-field shielding is actually the shielding that you put over the patient and to protect specific organs which are inside the field of view. Generally, they are made of light attenuating material because they still need to allow the X-ray penetration for the image formation. Out-of-field shielding is this contact shielding that you put over the patient, but to protect organs which are outside of the imaging field of view. They are typically made of highly attenuating materials such as lead. The work was performed within the EURADOS Working Group 12, dosimetry in medical imaging. So that's in the subgroup of patient dosimetry. Here you can see the list of the people who participated in the study. So what was the objective? Was to review current recommendations and legislative documents on the use of the out-of-field shielding in X-ray imaging, including those from national authorities and from international and national organizations and professional bodies. How did we proceed? Well, the work was carried out mainly in 2020. So we did an extensive review of available documents. In total, we gathered 81 documents, which almost 50% of the documents were coming from Europe. We had several documents from international organizations and other documents from other continents. We cover all X-ray imaging modalities, so radiography, fluoroscopy, mammography, CT, and dental radiography, and all kinds of patients, meaning adults, pediatric, and pregnant women. All documents were classified using a standardized approach. The scientific papers were excluded from the analysis, and the synthesis of the results was descriptive. The documents were classified in 3 categories. So we have those documents which recommend the out-of-field shielding, those documents we recommend not to use out-of-field shielding, and those documents where out-of-field shielding was not specifically mentioned. The documents analyzed were published in the period from 1982 till 2020. So here you can see the distribution on the year of publication of the documents. In blue, you see the legislative documents, and in orange, you see the recommendations. What are the positions of countries and organizations? So if you can see here, we have the 5 different X-ray modalities: dental imaging, CT, mammography, fluoroscopy, and radiography. So in orange is, I would say in yellow rather, is displayed those documents, the percentage of documents that were out-of-field shielding is not specifically mentioned. So which means around, I would say 50% of the documents, out-of-field shielding is not mentioned at all. In gray, you can see those documents, percentage of documents where out-of-field shielding is mentioned and is not recommended to use out-of-field shielding. And in orange, those documents where out-of-field shielding is mentioned and is recommended to use out-of-field shielding, which means that for those documents concerning that mention out-of-field shielding, most of them recommend the shielding. I'm not going to go in very, very much detail about the findings because this will take a lot of time, but I would just give you one of the example of results that we found. So you can see here is the documents considering gonad shielding for all patients and ages. So in blue concerns the male gonads, and in red it's about the female gonads. So in the first part, you can see the CT shielding. So in the left of this left part, so you have the CT shielding when it's recommended, and in the other side is the CT shielding is outside of field is not recommended. So you can see that it's mostly not recommend gonad shielding in CT. Either is for men or for women. But if now we look, for example, the example of radiography, so you can see for male shielding, the blue lines, it's mostly recommended in planar radiography for gonad shielding for males, but for female gonad shielding, it's not recommended. Well, and so on, you can see for the rest of the modalities. So when shielding of gonads is recommended, this is very often refers to male shielding because female gonads is most widely not recommended because of the variability in position of the female gonads. So the general findings is that in most countries, both legislative documents and recommendations are not specific enough. Here I gave some kind of sentence that we very often found in the documents. So, for example, facilities must have adequate protective clothing in order to protect the patient if necessary. So it's clearly not specific enough. All the findings can be found in this paper, which was already published in 2021. But just to conclude all the findings, we could say that there is a wide variation in countries, organizations, between those that recommend out-of-field shielding, those that do not recommend it, and those that do not state anything about it. The documents analyzed were published over 3 decades. Some of them might not be in line with recent scientific evidence. So we saw a huge diversity of recommendations, and for us, it was clear that more research was needed to derive clear and unambiguous conclusion. We should review the existing literature and our discussion among experts to identify gaps in the knowledge and trace future research studies. This is also how we joined the GAPS group. The GAPS group is from, it's the main bodies involved in radiation safety and imaging in Europe. And the objective of the group was to gain consensus on the subject of patient shielding, to write recommendations to the stakeholders, and to produce information for patient and staff in different languages. All the work has been published. I'm not going to go into detail because this is going to be the subject of the talk of Paddy Gilligan, who will talk after me. Just to let you know that since 2020, many things have happened. Meaning that there are new recommendations appearing. So for example, here I put 2 examples. One is the German Commission of Radiological Protection, who has edited now new recommendations. The same is true for the document, besides this one, which is the Swiss Commission of Radiological Protection. Now I'm going to talk about the second subject, which will be current practice. Again, within the GAPS group, we decided to do a survey to evaluate what is the current practice. The objective was to assess this practice in patient contact shielding among the different radiology departments and to assess their attitude towards a no-shielding policy. How did we do that? Well, from May till September 2021, the radiology departments were invited by the ESR Eurosafe Imaging Office to respond to an anonymized web-based questionnaire with 59 multiple choice questions. What are the main results? Well, we got answers from 225 radiology surveys from 35 countries. 195 centers perform examinations on adults. 160 perform also examinations in children. Out of this, 32 were specifically dedicated radiology departments for children. If we see at the results, the use of shielding in at least one of the radiological modalities is larger for children than for adults, with a value of 57% for children and 49% for adults. About the answer, would you follow European recommendations if provided by main European bodies? 85% of the departments say that they will follow these recommendations. Now, looking at the results of the gap survey, so here you can see the percentage of radiology department using out-of-field shielding. So for the different modalities. So you can see for in blue is the adult patients, in orange is the pediatric patients. So for adult patients, you can see that the most use out-of-field shielding, or the most, it's in for pregnant patients. Then follow this is the conventional radiography, followed by interventional radiology and the other modalities. Concerning the pediatric patients, is mostly used for conventional radiography, then for dental, and interventional and CT a bit less. If we now look for the percentage of radiology department using in-field shielding this time, if we look for conventional radiography, we see that it's mostly the same numbers as we had for out-of-field shielding, either for adult or for pediatric. And we can see that here in CT, in-field shielding is most commonly used also for pediatric patients than for adult patients. We were also asking in the gap survey for those already using contact shielding, which reasons were the most frequent reasons why they will use contact shielding. The more people, the answers were, I believe shielding is effective to reduce unnecessary dose exposure to sensitive organs, or shielding helps patients, carers, parents feel confident about the care they receive in 55% of the answers, or regulations require us to do so in 52% of the answers. So if we ask to these people who use contact shielding, what are the consequences of its use? Well, they say that sometimes in 73% of the cases, they answer need to repeat the study due to superimposition of the shield, or in 50%, artifacts were created, or increase of the dose due to the automatic exposure control system activation. Then we asked the centers not using contact shielding, the reasons why they will not use contact shielding. Well, in 60% of the cases, they said it's because contact shielding is not effective or needed to reduce unnecessary dose exposure to sensitive organs. It is because contact shielding may impair image quality and diagnostic capability of the examination and therefore require retakes. These were almost also 60% of the answers. And it is because the automatic exposure control may increase the dose in 52% of the answers. The centers not using contact shielding, how do they feel about this policy? In 71% of the cases, they responded, I am okay with this policy. If we now look at the summary of this gap survey, well, shielding, especially in children, is largely used despite concerns about its usefulness and effectiveness. Conventional radiology and dental imaging, both are low-dose procedures, but these are the modalities in which shielding in children is most frequently used. This could be explained by the long-standing habit of using shielding in these modalities. Gonads are the most frequently shielded organs, even though we know that there is no evidence of genetic effects, plus the radiosensitivity of gonads has been scaled back. It is well known that it's also very difficult to cover the female gonads with shielding because of we don't know where the exact position is. In-field shielding is commonly used in conventional radiology and less frequent use in CT, but in both cases, the practice is very questionable because of potential interference with the automatic control exposure system, plus some issues about image quality, especially in CT. So all these results, to go more into detail, there are many more results, so you can find it in this article which was published in 2023. Thank you very much. That's for my part, from my side.
Thank you, Marta. Thank you very much on this nice overview on the regulation and current practice. I suppose this would need to be updated regularly after some years. Now we move on. If some questions will be for Marta, we will answer to them at the end of webinar. And now it's my great pleasure to introduce Paddy Gilligan, the former president of the European Federation of Organization for Medical Physicists and the chief physicist in University Hospital, University College Dublin. And Paddy Gilligan was chair of this GAPS initiative, Gonad and Patient Shielding, a group that produced a European consensus statement. So I think we cannot have the better person to give us overview and some highlights on this European consensus. Paddy, please, the floor is yours.
Thank you very much, Zelka and Marta, for that great presentation. And it's an honor to work with, to be at this EURADOS 24th webinar on this topic. I'm Paddy Gilligan, and I was the former chair of the GAPS group. And I'm pleased to say I don't have any conflict of interest, apart from here's a picture of my hometown, Drogheda, on the east coast of Ireland, where they do make lead apparel that's sometimes used in the contact shielding we're going to talk about here. I'm also pleased to say my views are not personal, because they're based on a consensus statement. So I'll just be taking you through some of the themes that Marta mentioned around the pros and cons of contact shielding. I'll talk about the formation of the European consensus statement by the GAPS group, and then we'll go through each of the shields used in a routine radiology department. Looks at some practical issues when you do have to use shielding, and I believe we will have a discussion at the end of the webinar with questions fielded through the Q&A session. So just to say that radiation is still very much in the public domain, and we saw the film recently, Oppenheimer, and we also know that people are particularly sensitive around genetic effects. But as well as the media profile, for many of us who are radiology professionals, we are on professional registers, and sometimes to maintain these status, and these professional registers are very good in maintaining quality, particularly to protect patients and staff. But sometimes if you deviate from professional guidelines, you can be this kind of serious consequences for your career. So we need homogeneity. So say that a person moves from one country to another, that they have a reasonable appreciation and consistency of standards. Even within our own community, this is a sensitive topic, and these are slides from 2022, where we had a public debate. And again, this was repeated at the European Congress of Radiology in 2023, the winds of change. So we welcome such opportunities to communicate around this very sensitive topic, to create debate and information in the public space. Shielding is just one part of risk control, and it's generally considered the lower end of risk control. So in terms of radiology, we have our principles of justification, optimization, and as low as reasonably achievable. And in terms of risk of controls, use of controls, justification would be around elimination and substitution. And then optimization would be around engineering controls. Training would be come around administrative controls. And finally, the least effective is the use of personal protective equipment. The themes that Marta touched upon is, very common to all of the shields we really looked at, that inside the field of view, we've got potential for artifacts. They can actually obscure the clinical detail that we need to look at, which can lead to repeats. When automatic exposure control is present, there is the potential to interfere with us. Outside the field of view, we might get small absolute dose benefits with even smaller risk benefit. Artifacts can still occur in over beaming in CT, artifacts can still occur even though you're placing the shield outside the field of view. The potential to interfere with the automatic exposure control can still be there. And these are quite important considerations. Around 2009 to 2010, more and more information came out around the use of shield, the difficulty in placement, not being able to protect the organs which you want to protect. And these fed into a number of recommendations that Marta and regulations that Marta touched upon, both throughout Europe, and then these led to some statements, say, from the American Association of Physicists, from the NCRP, and they got quite a lot of debate and discussion at the time. And sometimes there was not concordance between all the different providers of radiological services. In Europe, there was a large number of these statements appeared between 2017 right up to 2021, but there was no general European statement. And recognizing this, we published in February 21 a commentary, myself and John Damalakis, Patient Shielding, the Need for a European Consensus Statement. With that in mind, we formed the Gonad and Patient Shielding, the GAPS group. And the aim, as Marta said, was to produce a consensus document on a number of types of patient shields. We are very lucky to have a European template for consensus documents in medicine, and they gave clear guidelines. And the purpose of our group was to build on and learn from what had been done before. And many members of our hardworking group had developed guidelines within their own, national societies. We did look at some newer papers, which led to some debate, and we wanted to produce a simple and clear to use resource that would be available to healthcare professionals. We're also very blessed to have Eric Breers, who's from the European Society of Radiology Patient Advisory Group, to provide us a patient perspective, and his input has been invaluable. We do recognize that this may represent change management because these shields have been in use for over 50 years. And we also recognize that this is a sensitive topic for some of the reasons that Marta outlined in that survey issued by the GAPS group in 2023. And also, these statements from the GAPS group are based on European technology and European culture and European trainings, and it might not be true for the rest of the world, and these are matters to be dealt with by, say, the International Atomic Energy Agency, the International Commission of Radiological Protection, and the International Organization of Medical Physics. We are very lucky to have, many of the hundreds and so thousand people working, providing radiology procedures in Europe, and we had a very good cross-section. And I sort of want to acknowledge, the role of a group like EuroSafe Imaging in allowing us to bring, these groups together, and we had pre-established working relationships, which did help. And here is the group who formed the GAPS group, and as I said, we were formed and we delivered in quite a period of time a set of guidelines that we believe was clear and easy to use. We also we used the cardiology consensus or European heart consensus model, where they used a traffic light system. And in this case, we use shields, and we would do red, yellow, and green. Sometimes for colorblind people, who it's particularly prevalent in males, they find a difficulty to discriminate between red and green, so therefore we use a diagonal band. In terms of gonad contact shielding, when we looked at the evidence and the benefits and risks, we felt that it was not appropriate to recommend gonad contact shielding. And indeed, some of the papers cited, some of these shields are no longer, such as the Goose shield, which you can see there, are no longer available on the market. In protecting the thyroid, in the case of dental, we did recommend in some cases that you might use shielding for both in and out of field of view. And some of the reasons for this are that, we may be dealing with, we're dealing with equipment without automatic exposure control, with very little potential for artifacts, and where detailed studies have shown for the equipment base that's there is the potential to provide good protection. In terms of thyroid contact shielding in non-dental applications, we did not recommend it. There was a recommendations from the American Academy of Oral and Maxillofacial Radiology published last year, and they reviewed the European consensus statement. You can see a table here. The text is rather small, but in round collimation, there was the difference of 0.3 milligray for the thyroids, where this difference was reduced to 0.1 with milligray with rectangular collimation for intraoral radiographs in dental procedures, which is one of the most common procedures in the world. There's still a large prevalence of circular collimation, up to 60, and the one I showed in the previous 60 centimeters, and the one I showed you in the previous 60 millimeters. The one I showed you in the previous slide, it was of 7 centimeters, and considering the demographic, that it will be a younger demographic, and that there was no potential to interfere with automatic exposure control, the European, we still believe that the European view on this has a strong merit. There was issues of infection controls cited in the American paper, and that's something that we will be looking at when we go to maybe update the guidelines. They did make an interesting point that we didn't recommend it in terms of thyroid shielding for mammography or for CT, even though there's dose reductions, but the demographic and the risks for potential for automatic exposure control and artifacts are stronger in those modalities. This may change as technology changes. In pregnancy, it's a very sensitive period. The expectant mother would have a high level of anxiety about radiation. And although you can get some small reductions in fetal dose, again, the potential to interfere with it or, other benefits and risks, we felt that it wasn't recommended in these cases. Similarly, for the eye shields, these were considered in detail, and again, these were not recommended when looking at it from a benefit-risk perspective. And likewise with the breast contact shielding, and in some cases, this has been shown to increase the doses depending on the type of shield used. Sometimes these recommendations are for routine radiological practice. In exceptional cases where shielding is used, we really feel that that you do have to have a length of that you have to have some training, that you need to know how to select the appropriate shielding, how to prevent it moving during a procedure, how to avoid interference with the automatic exposure control systems, and the selection of appropriate radiographic techniques. Many shields come in different lead equivalent thicknesses. They use different materials. They need to be assessed both at the start and then throughout the lifetime of the shield. And you need to perform quality assurance to do that. You need to know how to store it appropriate and lift it appropriate so you don't damage your back. Many of the shields have strict instructions around cleaning and disinfecting so that you don't compromise the integrity of the shield. We've got to remember that many of the patients, we've got a wide, diverse range of patients, and we have to respect patient dignity, particularly around protection of reproductive organs and of potential offspring. That and such examples would be transgender patients. So the frontline staff, need to have some very good training, and they need to have thought in advance about what they're going to say to patients. And Shane is going to deal with that in his webinar next, and also talking about communicating to the sensitive cohort of pregnant patients. So basically, to summarize the recommendations of the GAPS group, we only really recommended shielding to be used in specific dental cases. So with regard to the GAPS groups, we we're very blessed that we brought together the professional bodies involved in Europe in radiology, and we had a patient perspective. We did develop a consensus statement that built on previous statements. We believe it's clear and easy to use. We have a period for review and a guidance for exceptions. We're very conscious of intra-professional parity because we didn't want the issues clouded in, competition between professions. And therefore, we really set out to publish the statements in 3 journals simultaneously. And we achieved this in a relatively short period of time with the goodwill of people all around. And so I chaired up until the end of part 1, and taking over from me now is Claudia Granada, who has moved to the communications to professionals and patients. And they published their survey that Marta showed in June 2023. We also want to say that we're not ideologically or fundamentally tied to shielding, and we would encourage new research, and it's great to be involved with EURADOS, who produce and collate such research, and more sophisticated dosimetry to find out more about this valuable area of study, and including radiobiological work too. Here are the references for the 3 articles, which are identical. And just some information before I introduce Shane, to give you a pointer into Shane's talk, that nearly 50% of departments are still using shielding, and really, some of the reasons are around the expectations and around communication, rather than from hardcore scientific principles. And so that's a challenge for the GAPS group, part 2. So patient shielding is of limited value in risk reduction in routine clinical practice with the current radiologic technology in Europe. There are downsides in using shielding, that you can obscure pathology, you can introduce artifacts, you can interfere with automatic exposure control leading to higher dose. You've got manual handling issues with increased weight. They slow down workflow, and they have the potential for spreading infection. There is a consensus among the European bodies involved in radiology that its routine use should be discontinued. This is based on the current consensus at the end of 2021, but we will need to update these over time, and we've assigned a period of 5 years. But challenges remain, as this is change management for something that has been used for 50 or so years, or even longer. And here's some references, including some new one. And I want to thank you very much for this opportunity to collaborate with the hardworking EURADOS. And I'll hand you back to Zelka, who will introduce Shane. Thank you.
Thank you, Paddy. Thank you, Paddy, for this nice overview. And it's visible that behind all this is a really huge work. I hope that the audience will have some questions. Paddy, please feel free to use this opportunity to ask the experts. You can already put your questions in Q&A section. And now we move on to the 3rd lecture. It's my pleasure to introduce Shane Foley. He is a radiographer and also associate professor at University College Dublin in Ireland. And he is the current member of the executive board of European Federation of Radiographer Societies. So we will have also another point of view from a different society on these topics. So please, Shane, the floor is yours.
Great, thank you, Zaka. And I guess I follow Paddy as probably a 3rd member of the GAPS group, so just important to note that. But I guess where I'm going to hopefully present to you is, well, what next? Because what increasingly we're seeing is that different bodies and groups are recommending against the routine use of shielding. But in practice, it hasn't changed overnight. Okay, so we still have a large proportion of hospitals and clinical sites who are still using shielding. So we need to make a concerted effort in terms of, well, if we're going to stop using shielding, how are we going to do that? By informing our patients and caregivers as we go. Okay, so just to note, I don't have any disclosures or conflicts to make, only that I obviously am a member of, or was a member of the GAPS group, and I'm also a current member of the EFRS Executive Board. But what I hope to do in this presentation just today is really just to maybe help you to consider different communication methods, and importantly to understand the reasoning behind a no shielding policy, because as health professionals, we need to be clear first before we try to communicate that to our patients. Okay, because I guess with a lot of things in life, consistency is key. And when it comes to shielding, I think we're all familiar that shielding has been actually part of our, I suppose, modus operandi for over 60 years now. And we've been routinely using shielding for our patients, and they often expect it. I'll often have patients coming for an examination who will, if you don't position shielding, will then ask you for it, okay, because they're concerned themselves. And it's important because it's seen by patients as it's one of the few demonstrable acts that we take in terms of radiation protection. It's something clearly that our patients can see that we do for them to help protect them in this invisible world of X-rays. So we need to be, I suppose, not lose sight of that also, that it can be an important item in a patient's mindset. So to counter that, we obviously need to be proactive and take some steps. And I guess as professionals in healthcare, I think it's really important that we demonstrate consistency in our approaches. And it's quite clear from the recent GAP survey that this is definitely not happening in terms of the application of shielding, because we have about 40% of centres still using it. And even within the 40% of centres, we have it being used for some exams, not for others. And that just will lead to confusion for patients, because patients coming in on one day may get shielding and another day may not, maybe with a different radiographer or different examination. And again, as a profession, can we stand behind our practice and, I suppose, rationalize it and justify it? So that's the first thing. And importantly also is the fact that with any practice, we should be really adhering to evidence-based practice, which isn't simply looking at what the current best scientific evidence is, but also what our own clinical experience is guiding. So what our experiences and important, and additionally, what patients value. So we do have to take account of what patients want. And sometimes that might need extra explanations, extra discussions, and sometimes patients might actually even demand shielding. And that might reassure them. And that's something that we shouldn't dismiss either. So when it comes to the communication agenda in terms of making any change to practice or any change agenda, we need to firstly be very familiar ourselves with the reasons behind it. How is this big change coming about all of a sudden now and not previously? Because many schools, many practices, many hospitals still teach this as a basic radiation protection method of using shielding. And I know Paddy has touched on some of the benefits already, and we've seen some of that, but it's important that all of us as professionals can explain to our patients not just the benefits of shielding, but also any potential risks, what alternatives are, and also what would happen if you didn't do anything or didn't change the current practice. And we can summarize these quite, I suppose, briefly, really, in terms of what the pros and cons and alternatives are. And I think what the GAPS recommendation, the European consensus now, is that actually there's more risks involved with the use of shielding, and we actually have much better alternatives. And some of them from as simple as more attentive collimation or field restriction of your beam, and moderating your technique or individualizing your dose to the particular patient. Because it's clear, and even from the recent survey that was done, that 73% of examinations had been, our centres reported examinations being repeated because of shielding, and also 50% having artifacts included. And they're really important downsides to consider. So once we're familiar with those potential benefits, risks, and alternatives, then we can start the communication with our patients. And if obviously there's a number of different ways in which you can communicate to patients. And we're all familiar with these. They have their own pros and cons that go with them. And sometimes we need to use more than one. So what I did hope to do actually was to hopefully ask you a question, and I use an audience poll. So I might ask the team to launch that poll, and it should show up on your screen. If technology allows. The idea being that you'll be asked now, which single communication method do you think would work best at informing patients about no shielding? So just select one of those answers, and let's see if there's wisdom in the group. Okay, so just wait for a minute and we'll see if we can give people time to put in a few responses. Okay, great. Can we close the poll and maybe show the results? Super. Okay, great. So you can see here, there's, as expected, there is a bit of a mix, but I'm glad to see a slight majority are going for direct verbal communication, and I probably tend to agree with that the most. Okay, and maybe we'll come back to that in a second as to why it might be the best. Okay, great. Thanks for showing that poll. We'll go back to the presentation if I can. Yeah, super. And thanks to you all for answering. Move on slide. Great. So in terms of posters, so a lot of people said a poster would be useful, and there's lovely examples of posters that have been created by multidisciplinary groups, such as here, the BIR have produced leaflets, posters, combining frequently asked questions for patients, as well as posters that can be displayed, really to help inform patients or prepare them for this change in practice that they might experience or encounter. And all of these tools are very useful. Here's just some examples from the US, from the NCRP, where's the lead apron gone, essentially, and others such as from the AAPM, who have produced the AAPM Cares content. You've materials such as this produced in the Spanish language. So again, the good thing about posters is that they can be fine-tuned to local populations, made available in multiple different languages, and they can be very reasonably cheap and easy to produce. As well as that, I know the APM have produced a series of videos and modules as well to support all these learning resources for professionals as well as patients alike. So having a range of materials can be beneficial. But I would urge you to consider the limitations of each. Firstly, we know that approximately 25% of the population, that's the total global population, approximately over 2.2 billion, have some type of visual impairment. Okay, so knowing that informs you that patients coming into our departments, our clinics, may not be able to visually see something well, especially if they don't have their glasses with them. And coupled with that, our patients are often preoccupied with other issues such as anxiety-related conditions. On top of this, another downside of written materials is that literacy rates vary, and they vary the world over. I've just shown you a small screenshot here from the OECD figures showing you literacy rates across Europe. We can see even between Austria and Italy, there's almost a twofold difference in the number of the population who actually have an issue with basic reading. Slowly moving forward. So it's important to consider also, okay, having written materials available can be one thing, but we can also consider, well, where are patients more likely to get their information or to trust their information? And we know, and plenty of surveys have shown us, and research shows us that actually people in general tend to get their information from the internet. Why? Because it's easily accessible, readily available. But they also tend to seek first-hand information from interpersonal sources. Okay, and I draw your attention to this, that actually people want to get their information from other people. okay, and also trusted people that they know, okay, and that's really important to them. In terms of the persons who the people, I suppose, trust and like to get their information from, luckily, health professionals are right at the top of that in terms of trustworthiness, which is great to know. So they really trust the health professionals they're talking to. And we see this from multiple surveys in multiple different countries that have all the professionals, the medical professionals, are at the top of the list. So this goes in our favor. So really to take from this, there's actually people trust other people, and they also in particular trust health professionals. So word of mouth can actually be, and verbal communication is probably the most appropriate to avoid any issues with reading, literacy, and it can also make it more particular to the individual. So asking specific questions raised by a specific person. But just when you're communicating, again, there's a great publication from the WHO on this in terms of communication benefits and risks, is always aim to make it as understandable as possible without jargon, limit it to maybe maximum 3 key messages, and anticipate questions from your patients. So that means the onus is on us to prepare in advance, to know ourselves what the benefits, risks, alternatives are, and to be able to organize those into simple, clear messages that we can help our patients make an informed decision as well, and also be educated on the pathway. So I'd suggest, though, even though consensus documents and other publications are recommending this change comes at a local level. So we need to firstly, as individuals and as members of teams, look at our own local policies, see if they need to be reviewed, updated, perhaps audit as a tool for improving consistency of practice would be really important. And that's what I hopefully wanted to touch on and show you that communication generally requires a multifaceted approach, and individual communication is key with any big change or any main change from what we've done for a significant period of time. So thank you. I have a few references here for you to see, but I'd love to take any questions if you have any also. So thank you.
Thank you, Shane. From my perspective of view, we have, I think, 3 major points in all of this, let's say, topic and all 3 lectures. First, that regulations and current clinical practice differ among the countries, and it's not easily changed at national level. Second, that this new consensus introduced some new scientific proof, some new insights. So some changes are needed across different countries. And the third, that communication is it's very challenging, and it's not easy to introduce the changes in clinical practice, because, as you say at the beginning, the patients are feeling more comfortable if they receive some kind of protection, even though they are maybe not of use. So I don't know, question to all of 3 of you, how you think this will be implemented in the real clinical practice?
I think I might start. I think what we're seeing clearly is that it's not being implemented at a standardized level, and that there's quite a range of practices. And I think our next step is firstly, as professionals, to try and address that. I don't think it's something we should be happy with, to allow this continued range of practice, and that we should actually have these discussions and maybe see if we need to change local practices by having local reviews of policies, and maybe help educate both the workforce and our patients to try and address it.
Yeah, I would agree with that, particularly at an educational level, for training new healthcare professionals too. And I think there was a paper produced, I think it may be produced from UCD a number of years ago, on the difference and the heterogeneity of training around the use of shielding And they're examples that's where you start with the consistency, as well as that deliver local training and audit and all of those quality tools. And I think that we have to build on a clear message that is well evidence and science, and to be able to answer the questions from a group of professional associations working with radiation.
Yeah, about the question of introducing this into clinical practice, I totally agree with Shane. So this has to be discussed internally. This consensus paper that brings the idea of what has been discussed, but is very large from many people. Let's say it's a consensus. So it has still to be thought within the hospital how to bring it and discuss with internal policy, if any.
Thank you. I thought one, let's say, a question. Given the limited value of patient shielding in risk reduction, what alternative measures should be implemented to ensure effective protection of patients during medical procedure or are set up and emergency procedures, particularly pregnant women?
I think we can...
Maybe
Sorry, go ahead.
Yeah.
Marta, you go ahead. Sorry. No, you're first.
No, I was going to say that there are many new technical possibilities to reduce the dose. So it doesn't mean that just putting contact shielding will reduce the dose, but using what we have, for example, the modulation in the scanners and the possibility of reducing those, for example, those scanners that reduce those for the organs at risk. So when they go, for example, through the eyes and then increase the dose afterwards. So there are many options. And I think also choosing the right modality, choosing the right, I would say, device. So if you have a newer device, why not putting more patients in the newer device and so on. So I think there are many possibilities. I don't know if you want to add something, Paddy.
Well, I just want to say that shielding has been shown to, although some absolute dose reductions, but it's in terms of benefit risk, it really isn't one of the major areas that we can work on. So by using optimization and new technology and justification and audit, we can achieve a lot more. And I think by even focusing, even asking the question that you're asking there around the OR setup and emergency procedures, maybe if you look at those, that by auditing and seeing what your doses are and benchmarking them against best practice, you will get dividends for the patients that outweigh the potential benefit of shielding.
I see a very, I think, good comment with one of the colleagues. We as radiographers are the best radiation protection for the patient. We have the skills positioning, dose optimization, and etc.
Yeah, and I think just to add to that, exactly, I think there's a lot more optimization value from positioning, collimation, correct technique than there is from actually the benefit you'll get from any lead shielding use. So we know, and we've seen from multiple studies, that simply restricting your beam to the right size for the anatomy of interest will save your total patient dose by 50%. Whereas a lead shield might save organ dose by a small bit. So there's much bigger benefits to focus on, would be my suggestion, and I fully agree with that.
And probably the education should be on different levels for radiographers, medical physicists, radiologists, and of course at the end patients. We have one interesting question from Hugo. If you spoke to patients, I suppose, about this subject, what was their reaction?
So I think just from our experience with Eric as part of the GAPS group, Erica was our patient representative, because again, the GAPS group did involve the patient to make sure the patient's voice was listened to as part of this process. And what you find is, well, what we found from that interaction was that patients are very trusting of the medical professions. And if the medical professions think this is the best for their patient, they're happy with that. They really put a lot of faith in us and our actions, that we have the right motives. So once they hear it from us and they hear the explanation, they're generally quite happy. But if we don't address it, it just leaves questions unanswered. So I think that it just needs proactive, I suppose, communication.
Another comment. Other measures have the greater effect on radiation protections. Don't just leave out the lead apron, optimize the other measures, training courses, and so on. I suppose you agree. One question maybe to all of you from GAPS group. What is, let's say, the future plans of GAPS groups? Is it going to continue, let's say, to revise something in next period after a few years, or also is it going to be developed some communication materials and so on? What will be the extent of the future work of GAP groups, or this is now, let's say, the finished phase? And
yeah, I'll answer that. So we've handed over the next stage to the clinical professionals under Claudia, which is the communication of the findings of the original GAPS group. We do have an update period of 5 years selected, and we don't, scouting the literature for the last year or two, there hasn't been much there to really change, the thrust of what we found. So we believe that there will be some updates, and I think that will be done, with aiming towards the end of 2026. But in the meantime, I think the communication journey is the real one, and trying to make practice more homogenous in our European professionals working with radiology. I'm sure there will be more issues and more science turn up. So we would really welcome people to do research in this area, and to continue to communicate with us, and also allow us to have public forums like we have for EURADOS here today. So we would encourage that. So all of the above. But yeah, we're not going to I don't think the work is finished by any means. As with any consensus can change, which is a very good thing. It's science is the pursuit of truth. So this is the actual truth. So yeah.
maybe just one at the end provocative question so you were collaborating with different societies and also the patient groups. Who was the most, let's say, skeptical one about these changes and in the shielding policy?
We don't know, because when we presented it online, they signed on as anonymous, and they accused us of dishonesty and all of these sort of things, and that we were fooling the patients. So yeah, there was a number of cohorts, and I think we've learned, though, from the American experience, where we were very keen to have a consensus and very good party of esteem. And I also think we were blessed by the fact that a lot of us, had worked together, through platforms like Eurosafe and the IAEA and other places, that we knew and had strong degree of collaboration. So, and initially you're taken a bit aback at how passionate people are about this. And then really, once, we have the debates in the open, it's the best way of, really getting rid of the, the shouty extreme views, and concentrating on the facts, and, really with the patient center at heart. And I think, once you've, really thinking about the patient, that's where people will become more rational, and, they'll allow space for development of harmonization of practices.
One question was, is there an intention to create joint communication concept, probably on European level or something?
I would say yes, and that's what with Claudio, who, as I said, through platforms where we come together, such as Eurosafe Imaging, and that, where we can have access to healthcare professionals. And we've not to remember not to just confine this to radiology too. There's more and more people, in other disciplines who are maybe outside the direct radiology departments. We have to communicate with those too. So yeah, I think yeah, would there be future opportunities?
Okay, any final comments by Marta, Shane? If not, I really thank you for this nice overview and nice presentation. If anybody from the audience will have some more questions, they can address directly also to any of you. So we are very delighted to see that we have more than 200 participants, but probably some others will listen to the webinar online. So thank you very much again for your contributions. Thank you for listening, and we will see each other on the 25th EURADOS webinar, which will be announced through our newsletter, social media, and so on. Thank you very much.
And thank you.
Good afternoon.
Thank you. Thanks, exactly.
Bye.
Bye.